Good afternoon. I want to welcome everyone to this hearing to discuss the Department's views on the Military Compensation and Retirement Modernization Commission's recommendations for reforming the military health care system. Apologize for our tardiness. We understand there will be another vote coming up somewhere between 3:30 and 4, so we will try to get through as much as practically possible. We ask the witnesses to bring their statements down to 3 minutes so that we can get to questions, and then once the vote is called, we'll determine whether or not we need to come back. It's only one vote, so it should take no more than walking time there and back if we need to continue. As we studied the Commission's recommendations over the past 5 months, we considered the views of our current and retired service members through the organizations that represent them. We heard mixed reviews about TRICARE and the military health system. However, the consistent viewpoint is that TRICARE can and should be improved. We take their concerns seriously and will consider all views before undertaking any changes to the military health care system. That being said, I do believe that we can all agree that the work conducted by the Commission identified weaknesses in the current system that give us an opportunity to focus our efforts as we discuss reforming the military health system. It's our duty as the Military Personnel Subcommittee to get to the root cause of the issues and help determine the best course of action to fix them. Today is the first hearing where we will receive specific testimony from the Department of Defense on their reaction to the Commission's recommendations to improve health benefits for our service members and their families. I'm interested in hearing from our distinguished panel if they agree or disagree with the Commission's recommendations, or if they have alternative suggestions for addressing the perceived shortfalls identified by the Commission. In addition, I'm interested in hearing the Surgeon General's views on how the recommendations would specifically affect the future of the military treatment facilities and the direct care system. As I've said before, a guiding consideration for our work is to ensure that we can continue to recruit and retain the best and brightest in order to maintain the viability of the all-volunteer force, and ensuring that we do not break faith with our service members, retirees, and their family members. I would like to take this opportunity to ask unanimous consent to enter a statement from the National Association of Chain Drug Stores into the record. Without objection, so ordered. And before I introduce the panel, let me offer the ranking member, the distinguished woman from California, Congresswoman Davis, an opportunity to make her opening remarks.
Thank you very much. Thank you, Mr. Chairman, and welcome to all of you, all of our witnesses, particularly those who I've known from San Diego, and it's great to see you here, Admiral Faison. This topic, as we all know, is very important. It's very important to the committee. It's very important to the men and women and their families who serve our country. So as we move forward toward reforming TRICARE, we have to really hold on to this, I think, and really explore it well. We have a responsibility to ensure that we provide a cost-effective, world-class healthcare system for our military. And while we've had several hearings and briefings on the Commission's recommendations, this is really the first time that we've had to hear from the Department of Defense with their thoughts on the healthcare piece. And more importantly, this is an opportunity to begin discussing the best way to improve TRICARE and military readiness. The Department obviously has to balance medical readiness with the rising cost of health care, while at the very same time improving access, improving choice, and quality care for beneficiaries. We know that this is no easy task. I look forward to hearing from the witnesses on how they propose that we move forward. Thank you, Mr. Chairman.
Thank you, Ms. Davis. We are joined by a distinguished panel representing the offices of the Secretary of Defense and the military departments. We will give each witness the opportunity to present his or her testimony, and each member an opportunity to question the witness. Again, we would ask the witnesses to keep their spoken testimony down to 3 minutes. Your entire written testimony will be made part of the hearing record. Now let me welcome our panel. Dr. Jonathan Woodson, Assistant Secretary of Defense for Health Affairs and my former senior rater. Lieutenant General Patricia D. Horoho, Surgeon General of the United States Army, and I understand this is probably the last time that you'll be appearing before our subcommittee?
I hope so.
Well, I want to say thank you for your lifetime of service and looking out for the men and women in uniform, and for your passion and leadership on championing the performance triad. Lieutenant General Mark A. Ediger, Surgeon General of the United States Air Force, newly appointed. Congratulations and welcome. And Rear Admiral C. Forrest Faison III, Deputy Surgeon General of the United States Navy. Welcome, sir. With that, I'll turn the floor over to you, Secretary Woodson.
Thank you very much. Chairman Heck, Ranking Member Davis, members of the committee, thank you for the opportunity to appear before you today. The Military Compensation and Retirement Modernization Commission has performed a valuable service to the Department and the nation We agree with their overarching findings regarding challenges facing military medicine. We concur with many recommendations and have already moved to implementation. In fact, some members of this committee may recall that when I testified in this room in February of last year, I talked about the need to ensure an agile, relevant, and forward-leaning military health system. I stated that to meet our mission in these changing times, I had outlined for the MHS 6 strategic lines of effort. These include modernize the military health system management with an enterprise focus, the successful establishment of the Defense Health Agency, and the development of enhanced multi-service market represent signature initiatives. 2, define and deliver the medical capabilities needed in the 21st century. 3, invest and expand the strategic partnerships. 4, assess and refine the balance and needs of our medical force. 5, modernize TRICARE health program. And 6, define the MHS's requirements in terms of global health engagement. These strategic lines of effort will help us deliver on our overarching quadruple aim of readiness, improving the health of the population we serve, improving the experience of care in our system, and responsibly managing our cost. Our written testimony provides a more comprehensive summary of our positions on the Commission's recommendations. For my remarks today, I would like to focus on all of the strategic efforts underway to make the military health system stronger, better, and more relevant for the future. Here's what we've been working on to address the readiness requirements, ensure quality, and serve as effective stewards of the resources you have provided us. Over the last 2 years, we've undertaken a comprehensive review of our medical infrastructure and resources and presented a modernization plan that proposes to place our most skilled professionals in the military communities where they are likely to keep those skills sharpest. We've reformed the governance and established the Defense Health Agency and have provided a collaborative and affordable way for the Department to leverage economies of scale for those functions that are common among the service medical departments. And third, our system is implementing recommendations that emerged from the Secretary's review of the military health system and culminated in the Secretary's action plan of 1 October 2014. We are making it easier for access to care in our system. We are focusing on key measures of quality and safety and participating in national quality improvement initiatives such as the Partnership for Patients. And we are making our performance data more transparent for our beneficiaries and the public to see. Similar to achieving historical survival rates on the battlefield, our leadership team will be relentless in our efforts to be a national leader in quality and safety in all that we do. And finally, we are reforming our health benefit. TRICARE is an exceptional health benefit tailored to meet the unique needs of military families. Elements of TRICARE can be improved and must be improved, and that work is underway. We have released an RFP to recompete the national TRICARE contracts, and we have included provisions that reward innovation and simplify administration of the contracts. In summary, the military health system is a unique and indispensable instrument of national security. Our mission is supported by some of the most respected medical professionals in the world and attracts an extraordinary pool of young medical professionals who understand how compelling and vital this system is to others. We are fortunate to be entrusted with serving as stewards of this system, and we take this seriously. So I'm grateful for this opportunity to be here today and to answer your questions.
Chairman Heck, Ranking Member Davis, and distinguished members of the subcommittee, thank you for this opportunity to provide the Army and Army Medicine's perspective on the health care reform recommendations. After 13 years of war, the Army remains globally engaged. Any changes to the compensation and benefits must not only honor their sacrifices, but preserve the long-term viability of an all-volunteer force. The Army supports the underlying objectives of the Commission's health-related recommendations. However, we do have concerns regarding certain elements that threaten readiness and our medical skills. It is critical to understand that our direct health care system connects with the battlefield and exists to provide health readiness to our soldiers and their families. This is what separates us from the civilian healthcare system. Our hospitals are our readiness training platforms, which produce a ready medical force and a medically ready force. It is a system that performed so well over the last 13 years of war. We concur that a comprehensive list of essential medical capabilities, or EMCs, should drive our training and resourcing. However, those EMCs must address the whole spectrum of health rather than focusing solely on combat trauma and surgical capabilities. For instance, less than 1 out of every 5 service members evacuated from Iraq and Afghanistan were injured in battle. During Operation United Assistance, the major threats to our soldiers were endemic infectious diseases. The Army already utilizes joint structures and mechanisms to identify, monitor, and report on medical readiness. We are working to integrate EMCs into these processes. Therefore, the Army does not support establishing a 4-star readiness command. The Army supports the Commission's objectives of affordable health care and increased choice for our beneficiaries. However, the Commission's recommendation to establish TRICARE choice would negatively impact our readiness of our entire healthcare team and present financial challenges to both active duty families and retirees. Currently, non-active duty beneficiaries comprise 67% of our total beneficiary population, 83% of our inpatient care, and 79% of our high acuity inpatient workload. These patients are vital to the sustainment of our 148 graduate medical and health professional education programs. The loss of these beneficiaries from our direct system would pose tremendous risk to our training programs and negatively impact our medical forces readiness posture. The Army sees financial risk to soldiers and to families and injured in the Commission's recommendation to offset TRICARE choice costs through a basic allowance for health care. Year-to-year health care expenses are unpredictable, and many areas of our country are medically underserved. In conclusion, the Army needs a medically ready force. When the gate on the Stryker opens, commanders need to know that it will be full of soldiers that are ready to deploy. And the Army needs a ready medical force. When the wounded soldiers hear the rotor blades of a medevac helicopter, they need to continue to have confidence that our providers are trained and ready. Any radical departure presents significant risk to a system that has produced record levels of both combat casualty survival and readiness. I'd like to thank the Congress for your continued support. Army Medicine Team is proudly serving to heal and honored to serve.
Chairman Heck, Ranking Member Davis, and distinguished members of the subcommittee, thank you for inviting us to appear before you today. The Air Force is truly grateful for the hard work of the Military Compensation and Retirement Modernization Commission. Many parts of the Commission's recommendations will enhance and facilitate programs that serve our airmen, their families, and our veterans. Today I will speak to impacts in 2 areas of primary importance for the Air Force based upon our analysis of the Commission's recommendations. I will begin with the impacts on the readiness of our medical force. We appreciate the Commission's focus on the linkage between care provided in our hospitals and the readiness of our medical force. We found their proposal to identify and quantify readiness-related essential medical capabilities helpful to focus efforts on the capture of specialty care for our hospitals. That concept builds upon the Readiness Skills Verification Program we've utilized in the Air Force for over 15 years to set clinical standards for the readiness of our medical force. However, we do not see the need for a Joint Readiness Command, as existing processes jointly utilized by the services enable us to measure and assess the readiness of our force. We have significant concern about the impact the Commission's health plan recommendations would have on the readiness of our force. We believe the proposal would shift family member and retiree care significantly to the private sector and thereby move care essential to our readiness out of our medical facilities. We also believe the proposal to place our medical facilities into competition with the private sector would drive up administrative costs and significantly detract from the focus on the operational mission in our medical facilities. The second area of primary concern centers on our support to active duty families. We believe resilient families with excellent health service support greatly enhance the resilience of all of our airmen. We support changes in the President's budget to improve TRICARE while enhancing our readiness. Additionally, significant progress in the strategic line of efforts referenced by Dr. Woodson has occurred, and we are a progressive system of health and readiness as a result. We are concerned that the Commission's proposed change to the health plan would increase stress on airmen and families by requiring them to navigate a complex insurance marketplace on a recurring basis. We are concerned that the Commission's proposal would shift family care significantly into the private sector, thereby creating a hole in the safety net commanders depend upon for active duty families under stress. Proper balance in the mix of our medical force is important to maintaining a ready medical force while providing safe and high-quality health services. The National Defense Authorization Act of 2010 permanently prohibited the services from converting non-military essential active duty medical positions to civilian positions. Relief from this prohibition would enable the Air Force to judiciously increase the proportion of civilians in its force mix. I thank the committee for your continued support for Air Force medicine and the opportunity to answer your questions today.
Chairman Heck, Ranking Member Davis, distinguished members of the subcommittee, thank you for the opportunity to appear before you today. The Navy appreciates your leadership in establishing the Commission and commends the Commission for their thorough and independent assessments. We remain guided by our Navy medicine strategic priorities of readiness, value, and jointness. We note that the Commission recognized the importance of these imperatives, and many of their overarching objectives are largely aligned with our strategic priorities. Following the release of the Commission's final report in January, Navy Medicine participated in the DoD-led rapid and comprehensive review of the healthcare recommendations. While there is general support for the underlying objectives of the recommendations, I will briefly highlight some of our perspectives and concerns regarding them. In relation to medical readiness, we do support establishing common and service-specific essential medical capabilities, or EMCs, as they could be an effective means to monitor readiness and guide resourcing decisions. We note, however, that EMCs must be developed for more than just surgical trauma skills. Military medicine supports a wide range of operations, including treating disease and non-battle injuries during military operations, as well as providing humanitarian assistance and disaster relief when called upon in crisis. While there is general agreement to the Commission's objective to provide an affordable health benefit with additional choice, we must recognize that our medical centers, hospitals, and clinics are our most important readiness training platforms for our military medical personnel and critical to sustaining vital skills and clinical competencies of them. The availability of case mix, volume, complexity, and diversity is vital to having a trained and ready medical force. In this regard, care of our beneficiaries is inextricably linked to our readiness mission. Patient enrollment is fundamental to our approach to maintaining the health of our patients. The military health system is working hard to recapture workload into our direct care system and leveraging initiatives like our patient-centered medical home program to improve access and care. Navy medicine is leading forward in these areas as they continue to show progress. We believe that the Commission's approach to offer greater choice through the use of commercial insurance plans presents risk by reducing patient volume and case mix in our system and positioning MTS at a significant disadvantage in attracting patients when competing against commercial insurance plans. The careful assessment of the recommendations for exceptional family members requires additional time. We agree with the objective of expanding services to help family members with specific needs, but more work is needed to identify which specific services among the many state Medicare waiver programs are most meet their needs. Regarding the DoD and VA recommendations, we support the goals of the Commission, but we believe that the current Joint Executive Committee has sufficient authorities to realize the outcomes desired by the Commission. Throughout Navy medicine, we work closely with the VA in assessing opportunities to collaborate and cost-effectively share services to meet the needs of service members and our veterans. And we have several unique collaborations, sharing agreements, and partnerships already in existence that benefit both departments' beneficiaries. We are working with the Assistant Secretary of Defense for Health Affairs, the Defense Health Agency, as well as our sister services to incorporate many of these opportunities in the MHS. Some changes can be accomplished within existing policy, while others may require legislative changes for which we would appreciate the Commission's and the Committee's support. In summary, we need to recognize what sets us apart from civilian medicine, that we are a truly rapidly deployable, fully integrated medical system. This capability allows us to support combat casualty care with unprecedented battlefield survival rates, to meet global health threats, as we recently did in deploying labs and personnel to Liberia in response to the global Ebola crisis, and to our hospital ships, Comfort and Mercy, deployed today and underway supporting missions around the world. We must also understand that our readiness mission is directly linked to the training and skill sustainment our personnel do every day in our hospitals, in our clinics, in our labs, and in our classrooms. We cannot expose our direct care system to risk that could negatively impact our readiness posture. Thank you very much.
Thank you all for your testimony. We will now begin a 5-minute round of questioning from each member. I will defer my questions to the end and recognize the junior member of the subcommittee, the gentlelady from New York, Ms. Stefanik, for 5 minutes.
Thank you, Mr. Chair, and thank you to all of our witnesses here today. I wanted to focus and address my question to General Horoho. I represent New York's 21st District, which is home to Fort Drum, and part of the 10th Mountain Division is based at Fort Drum. Later this summer, I plan on hosting a listening session with various service members and their families to hear their feedback on the Commission's reports and health care plans going forward. And Fort Drum is unique, as you know. There's no hospital on post, and we have a very strong partnership with civilian hospitals like Samaritan and River Hospital. I think you visited Fort Drum recently to assess that partnership. Can you talk about whether there will be an impact for active duty service members because of that unique relationship, because there's no on-post hospital?
Thank you, ma'am. I think if I understand the question correctly, are you asking whether or not there would be an impact if we move towards the Commission's recommendation on Fort Drum?
Correct.
Okay. I do believe there will, and the reason why I say that is that right now, many of the readiness skill sets, even though we have a unique capability there with the clinic, and then we have a strong partnership with the civilian facilities, we still rely on a large family member and retiree population getting their care at Fort Drum proper. That allows us to enhance our readiness skills of our medics, as well as our clinicians, our orthopedic surgeons, and the entire healthcare team. If that population goes out to one of the 11 different plans that are out there, then we become competition with the healthcare plans, and it's an unpredictable population that we would be able to treat.
Great, thank you very much. And then I just wanted to ask broadly, can each of you talk about the kind of listening sessions that DoD has done to understand the concerns directly from the service members? I know that's a large question, just broadly, if you can answer that.
Sure. Let me start, and I'll let the Surgeons Generals follow on. Just, briefly, coming out of the MHS review, we conducted town halls. Of course, we routinely, in fact, use survey techniques to find out what is going on. And for the sake of brevity, I would just say that the evaluation of the TRICARE program, Access, Cost, and Quality, the 2015 report to Congress, contains a lot of good information about what we do to survey our population, to adjust the program and understand where we're at and where the improvements need. And I would just recommend that to you.
Yes, in addition to what Dr. Woodson referenced from the MHS review, which was very valuable and helpful, each of our medical group commanders has a panel in which they conduct regular listening sessions of people who consume their health services in the local community. We have a process by which the findings and the trends from those sessions are fed up and centrally analyzed for trends, and we found that to be a very helpful process. In addition, each of our medical groups uses social media to solicit input and feedback from the people that consume their health services, and we also use social media centrally for that purpose.
Great, thank you very much. Did you want to add?
Oh, yes, ma'am. Same in the Navy. We conduct regular town hall meetings. We have an expectation that all of our COs will regularly attend the healthcare consumer councils at each of our bases. And whenever we travel, we make a point of meeting with every line commander to solicit their input. We also are very active on social media to get feedback in.
If we're going to go all the way straight down, I'll do the same thing then. In addition to, because we're very similar in our approaches, the other one are virtual town halls that actually conducted from the Chief of Staff of the Army on down to get the feedback from our beneficiaries and being able to hear their voices and their concerns. We've also had high reliability summits to be able to educate both our active duty professionals in the healthcare business, and then we take that back to the commands, and then they share information with the beneficiaries as well.
Great, thank you very much. I yield back.
Thank you. Ms. Davis?
Excuse me. Thank you, Mr. Chairman, and I appreciate, again, all of you being here. I'm not sure if my questions are related, probably are, but first, you did talk a little bit about the loss to the beneficiary, because if in the Commission's recommendations we had a different system and training of medical personnel was critical to that. So I wanted to ask about that, but also about the fact that the commission determined that EMC's, the essential medical capabilities, are not clearly defined, and they suggested that the DoD had not established the clinical proficiency standards for military medical personnel and facilities based on widely accepted metrics. So, you may not agree with that assessment, but I wanted to know how you see that assessment and what you would propose. And if you can attach it to training, that would be great, but maybe that's a totally different question, so.
Yeah. Maybe I can start, and again, the Surgeon Generals can add on. From a context point of view, one of the things we have to understand is that medicine really has evolved. So 4 decades ago, a doc may have been a doc and a nurse may have been a nurse. And today, with subspecialization, the idea of what the competency is and how to maintain that competency is radically different. And so the issue really that we got to, again, as part of the modernization study and some of the self-analysis we were doing, is identifying what the specifics of the skill set should be by specialty and military occupational skill set. And this is really big work, but important work to do. So we self-identified prior to the commission that we needed to focus on this issue of better defining readiness, competency, and being able to measure that. And I think the Surgeon Generals have done a great job, and Air Force, I think, has a great matrix that they use, and the other services have their metrics as well.
Thank you, ma'am. We've looked at this over the last 3 years. This has been a culture shift across Army medicine, and really looked at our hospitals as being our readiness training platforms, because that's where we house our graduate medical education programs and our health professional education programs. So we rely on a constant beneficiary population that gives us the complexity in the case mix. We evaluated where we had our active duty, that there was a mismatch a couple years ago where our green suiters were. They were in more of the smaller areas, and then we had contract personnel and civilians more in our medical centers. Those medical centers are where we need that complex capability and readiness skill set training. So we've started migrating and shifting where our active duty population is. We've also looked at it from not just combat casualty care, but actually the readiness skill sets that are needed for every single one of our service members that are part of the medical team. And so I'll give a good example. We looked at substitutability. So we may have rheumatologists that we need for our day-to-day health care beneficiaries, but for deployability, we're identifying what are the wartime skill sets that are needed for that specialty so that they can be substituted for a surgeon on the battlefield. And so we are now down to that level of detail of really looking at it. And in addition to that, we now have standards in place where I can assess the readiness of my military treatment facilities. I can assess the individuals. And now we have just rolled out, with all 3 services using it together, a surgical tool that allows us to look at every one of our operating rooms, the number of cases that are needed, the complexity, and then being able to look at that in addition to assessing our surgeons.
Thank you. I think I'll go ahead and have the surgeons respond. And I think part of my question around this too, and the whole issue, I know Admiral Faison will, and I talked about this a lot in San Diego, because there is this concern, and it's partly why the commission addressed this, is the mix in terms of the patient population and the ability of medical professionals to have access to be able to help those and treat those who are coming from a more diverse and a larger population. And so I guess I'm just trying to get at that as well, in terms of whether the mix that you have is adequate to do that, since we also are looking at the general public to help with that. We know that military medicine is not going to be able to support that always. And
Yes, an important point is that when we talk about essential medical capabilities and clinical currency, we're talking about that within the context of readiness, the clinical skills that are needed in a deployed environment, which don't always exactly match up with our day-to-day practices at home station. And so in the Air Force, we've had a process that by specialty, we actually define case volume and mix and skills that actually translate into the deployed environment. And then we keep records and we track the extent to which we're able to meet those requirements and keep clinicians ready. In some cases, you're right, our population doesn't really have the demand in certain procedures that would support our readiness requirements. And so in the Air Force, we've used strategic partnerships in some cases, and the other services have as well, to send selected clinicians to other places under training agreements to make sure they're current in those types of skills. I think what we've all decided to do together is to actually incorporate these standards for clinical readiness into the measurement of the preparation and readiness of our forces and present that jointly, the same way our combatant partners in the line present the readiness of their forces.
Thank you. I know my time is up. Thank you, Mr. Chairman, for those additional minutes. Thank you. We'll get it later.
Mr. Chairman, thank you very much. And Dr. Woodson, I wrote you a letter on May 19th, and I would like to make reference to that. First, I would like to share with you and the panel a email from a Marine's wife down at Camp Lejeune, which is in my district. And I start with this from her email. 2 weeks ago, on April 13th of 2015, he attempted suicide. He has severe PTSD, a TBI because of an IED explosion, and has severe physical ailments associated with the blast. He was placed on a ventilator for about 12 hours as a precautionary while the pills he had overdosed on worked their way through his body while he was sedated and unresponsive. The reason I wanted to bring that forward is because many of us, not all, but in Congress, including Senator Vitter, have been very supportive of an option that we would hope that the Department of Defense would give to the medical doctors in all services, that should the doctor decide that maybe hyperbaric oxygen treatment might be a way to treat PTSD and TBI. I'd ask in the letter I wrote you that you respond and not Admiral Wagner. We had written Admiral Wagner and asked that the hyperbaric oxygen treatment that Admiral Mullins himself saw go to Camp Lejeune remain there and be put in the Intrepid Spirit Concussion Recovery Center at Camp Lejeune. Obviously, his response back was not very encouraging. So let me go to this paragraph. How much money was expended by DOD on medication in 2014 to treat PTSD and TBI for active duty military? As we know, certain medications have been implicated in the suicidal epidemic in our veterans. Are you aware that Dr. Harsh study published a statistical significant reduction in suicidal ideation in the HBOX treated veterans? And this was accomplished in veterans with the combined diagnosis of TBI and PTSD. Do you have any DOD studies showing the same with any other therapy? I don't expect you to answer that today, but I'm looking forward to your answer. What is so ironic to Marines down at Camp Lejeune is that in this Intrepid Center, they can be treated with yoga and acupuncture, but they can't be treated with hyperbaric oxygen. To many of us in both parties, House and Senate, we just don't understand why and how that the Department of Defense in their studies say that they do not see where hyperbaric oxygen treatment would be a positive. And yet Dr. Harsh, who is the foremost expert at LSU on this treatment, has even offered, and I've written to Secretary Mabus, that he will take 12 Marines from Camp Lejeune at no charge to DOD, and LSU will absorb it to treat them for 8 weeks. And I hope that you will take the time to read carefully at what we're asking you. As you know, Senator Vitter, and Landrieu asked for an Inspector General's investigation as to how the Department of Defense, the different studies, have studied hyperbaric oxygen and why they do not think this would be helpful to those with PTSD and TBI. So I hope that you will answer this letter. Again, it was May 19th, and I want to give you, as I would anybody, 6 to 7 weeks to respond back. But when you read, I've never heard of any soldier or Marine or anyone that had the treatment of hyperbaric oxygen that committed suicide. Yet when they're medicated, we're averaging maybe 20 or 21 a day committing suicide. I don't understand, sir, why this treatment will do no damage. If it doesn't do any good, it doesn't do any damage. I guarantee you it would do more good than yoga or acupuncture. Will you promise me today in this committee that you will respond back to this letter that we have written you?
Absolutely.
Thank you, Mr. Chairman.
Yeah. Mr. MacArthur, questions? Okay. So we had a briefing from the current TRICARE Administrative Service organizations on how they viewed the Commission's recommendations. Obviously, they all have a non-military health insurance option that they also provide. And they stated that they felt that there would be opportunity for them to address some of the shortfalls or deficiencies identified by the Commission if they were just allowed to utilize some of the best practices that they have on their non-military side on the military side. For instance, moving away from fee-for-service to value-based care. So, Dr. Woods, I know we've had this discussion a little bit offline. You know, as the TRICARE 17 contracts, the RFP is out, what would be the pathway to be able to, one, provide the authorities necessary to allow some of what's being done on the civilian side to come into the military side as far as managing health care? And how would that happen if the TRICARE 17 contracts are let prior to those changes being made? Would it be a mod? Is there a benefit to just extending current contracts till we figure this out? What do you believe is the best way forward?
So thank you very much for that question, and we fully endorse moving toward utilizing value-based care in the management of both the TRICARE contracts and our patients to their betterment. As we move to 2017, again, we've approached it in a more disciplined way, and in fact, we're looking for the authority to use value-based care. Now, as it relates to the flexibility, remember, there's a common misperception about the contracts that they're kind of 5-year locked-in entities. They're not. In fact, they're 1 year with yearly options, and we modify contracts all the time. Continuing the extension of current contracts is costly, and in fact, it just maintains sort of antiquated systems. And so as we move more to trying to use utilization management tools, big data, to better define and manage our populations, it's very important that we modernize the contracts. But we can incorporate all of those things and fully anticipate incorporating all of those issues into the 2017. And lastly, we've already moved out in terms of value-based care. We have a demonstration project right now in Maryland in which we have a pay-for-performance model. And lastly, we're working very closely with Medicare on their work group to define particularly those outcome parameters that are important in making sure you have success with value-based care.
Great. That's very encouraging. I look forward to continuing to work with you to make sure that DOD has all the authority it needs to be able to capitalize on some of these proven strategies that are currently forbidden or prohibited from being utilized in the military healthcare system. One of the other areas that was brought up is, of course, the importance of patient data and data analytics. And, you know, it seemed like there was a disconnect in being able to have all the data to adequately manage a patient's care when the prescription part of TRICARE is not part of any one of the ASO's service lines. And it was brought forward that perhaps, and as I understand it, prior to my arrival here, it was Congress that said, go ahead and go out and get a separate PBM. But the idea of bringing prescription services back within the ASO contracts, thoughts on that?
Well, I think it's very important, I guess, to address the central point of making sure there's a single point of accountability for the coordination of all of the benefits and care. And that's one of the issues that concerns me about the commission recommendation. So if you look at what would have to happen, we'd have to disestablish the DHP, disestablish TRICARE. We'd have to have OPM establish this choice network with navigators, because it would be very important. They'd have 250 programs, which the service members and beneficiaries would have to negotiate. We'd have to expand the MERCF fund to cover the health care and pharmacy programs for non-Medicare eligible retirees. Funds from the services MILPERS would have to be transferred to the Employees Health Benefit Fund managed by OPM for active duty family members, reserve component of family members. For gray area retirees, that is non-Medicare, funds should also be transferred from MERCF to the Employee Health Benefits Fund managed by OPM. We'd have to establish a new trust fund, which would be managed by DOD to finance existing pharmacy and dental programs for active duty family members and reserve components. MTFs would be funded through a revolving fund and using reimbursements that they receive for care. And the services O&M counts would be at risk for shortfalls, and we estimate that would be about $2.4 billion a year. And we'd have to establish a catastrophic fund for active duty family members. Now, the key here, though, and then DOD would still be responsible for pharmacy, dental, vision, the basic allowance for health care, the networks for active duty service members, the networks for overseas active duty service members, which there's no mention of how we would handle that in the commission report, ECHO. And so the important issue here is that if you take it from the point of view of the beneficiary, and let's just say, for example, we take an active duty family with an exceptional family member, a child with autism, let's say, they're going to have to deal with these private insurers for the health care, and then they're going to have to deal with us for other things. And if they have cost overruns, then they're going to have to try and get into this catastrophic fund. That's a lot of touch points. And then if you add to that the highly mobile population we have, I think that there's substantial risk when you don't have a single point of accountability for the entire health benefit. Substantial education for retirees, substantial education for beneficiaries. So I think there are some risks, and I think there are easier approaches to reforming TRICARE to make it exceptional. And I think that's where we would love to work with Congress.
Great. We'll go for a continued round until we get called for votes. Ms. Davis?
Thank you, Mr. Chairman. And perhaps Dr. Woodson, I can pick up on that, and I hope the others will join in too. And one of the things that we heard with the commission was I think they were a little displeased, actually, when they heard that there was a kind of protectionism coming through, that surely our military families might not be able to navigate multiple systems like this. And I think you all said as well that, you know, it's harder to navigate the more complex system. So I wonder if you could respond to that a little bit, because I understand exactly, you know, what you're saying, how important it would be to have a point of accountability, but at the same time, there was a sense that somehow we couldn't provide the support system to enable families to be able to utilize that to the best of, you know, to serve their needs. And if you can expand on having more options for families, more choices, as they talked about, that seems to be a good thing, and maybe we shouldn't get caught up in whether or not they can navigate it. So help me out with this a little bit, because I don't think that's really the reason to not do this, of course. But
No, I'm sure the Surgeon Generals will have, that's a great question, and the Surgeon Generals will certainly want to say something about this, but let me just say this, that when I go out and talk to folks and when I look at surveys, choice is not about wanting to navigate through 250 health plans. Choice is expressed to me as ensuring that I have a robust health benefit that will take care of my health needs when I want it. And then the real choice is about being able to see the provider that I want when and where I want them. And so if you look at PB 16 and 15 proposal, it was about giving more choice to the family members so that they wouldn't have the hassle of authorizations and referrals, and they could choose when and where they wanted to see, the doc or the provider. That's, I think, the choice that they want, not necessarily a lot of programs. By the way, when you boil it down and you go into the commercial market, you really find three types of programs, right? You find health maintenance organizations, which is similar to our Prime. You find fee-for-service programs of two types. One is preferred provider, and one is, again, more open fee-for-service. We have those, basically. So they're not going to have really different choices in terms of types of plans. They're just going to have to navigate through more insurance programs and not have a single point of accountability.
Ma'am,
Yeah, go ahead and we'll go backwards.
I'll address this with a typical case from the Navy. 35% of the Navy is deployed in any given day. So, and 75% of our sailors were born after 1986. They're very young. And so the typical sailor is married with 2 children. So stationed, let's say, in San Diego. Ship is out at sea. Right now, if that family member has a problem with their health care, they call the CO of the hospital. It's one point of contact. So I want to distinguish between navigate versus advocate. And so if there's an issue, they call one person. If we allow them the choice, they're navigating several hundred health plans. As a CO of a hospital, having just been one, I have no leverage over those plans. So how do I advocate for that mom and their children? And if one of those children is a special need, she's dealing with the health plan for part of her health care needs. She's dealing with DOD for the special needs part. She's dealing with DOD somewhere else for pharmacy. It's overwhelming while you're trying to balance 2 kids as a single parent and your grandparents are back in Texas, as an example. So we're worried that we're adding to the plate of our service members to get a benefit, where right now they've got a kind of a single point of contact to pick up the phone and help them.
Great. And of course, we know a lot of those are ombudsmen as well. who
yes,
are
ma'am.
That single point
Absolutely.
of contact. And wonderful in San Diego. Sir.
And I would agree with that completely. It's not that we think the families are incapable of navigating. We just see the complexity of it as another source of stress for families that we know are already under stress by virtue of the service and the ops tempo that they're a part of. I think the other thing that would be challenging in that venue is that if we have families who have a variety of different health plans that they've chosen on the marketplace, those plans come at different prices. They will have different ranges of benefits. And so we have a remarkable system between all 3 services of employing the medical home concept in the way we provide primary care. And so with that comes timely prevention and a coordinated team-based approach to care. That becomes more difficult to apply if you're dealing with a patient population that's got a variety of different types of health coverage. And so we think we can do a better job of providing continuous support to their health and performance over the time of their service to the nation if they're getting their care continuously in our MTFs.
And ma'am, in addition to that, because we're pretty similar in all of our responses, I think the importance of the care coordination can't be understated, especially when service members are deployed. And when we looked at the area with behavioral health, one of the things that we realized is we had to be very unique in the way that we supported families or children that had stressors due to the deployment. So we took our behavioral health and were able to embed them into the school-based programs. When they're out into the civilian sector, those types of unique options are not going to be available to respond to really timely needs. And I think the other piece of it is, as we realize when healthcare is changing or opportunities to be able to be much more responsive in the area of health, that allows us to employ all of our capabilities together using tele capabilities to really reach our patients where they need their care.
Yeah, thank you. Thank you, Mr. Chairman.
Mr. MacArthur?
Thank you, Mr. Chairman. I'm sorry I missed your opening remarks. I would have been very interested in hearing them. But a lot of the discussion on this part of the Commission's recommendations has been around the quality of health care to our military families, and rightfully so, and that's why the 4 of you are here with that focus. But some of the Commission's focus was on the financing of health care, and that's given rise, I think, to a lot of the recommendations. And as I think about that, the financing of it, the creation of a structure, and they've gone down the private route, and I think there are other views that fixes to TRICARE would be a better approach to that. I worry about the next iteration. So we make fixes now, and then the market, the broader marketplace continues to evolve, and new programs allow the non-military healthcare world to make changes and get efficiencies, and TRICARE is stuck in whatever new model we create. And so my question has to do with how we create a self-evolving TRICARE. Let me explain what I mean with that. Something that doesn't require an act of Congress every time we want the program to be able to keep pace with what's going on in the marketplace. And I think this concept is essential, and this is why I've been somewhat supportive of the private market idea, although I think there's problems with it. And so I'm now back in my thinking to what do we do to TRICARE so it can evolve without you coming and getting 435 members, half plus one, to agree to that. I'd be interested in your insights on that.
So let me start again, and certain generals can follow on. That's an excellent question. That really is the heart. So one of the things I think we all need to consciously understand is that TRICARE is not an insurance program. It's a defined federal benefit program in which it's guided by laws and statutes and the like. And that was probably very appropriate 2 decades ago. What we need to, again, I think, partner on is giving the flexibility to the administrators of the program to evolve the program in real time to take advantage of what's occurring in medicine. So I was very thankful to Congress when last year they gave me the ability to look at evolving medical technologies and implement them without coming to Congress right away. And that was just new. That's new. But it's that kind of thinking. I had this discussion with some folks, and it was about, it had to do with something we wanted to do with TRICARE. And the lawyers at the time were telling me, no, you can't do that, no, you can't do that. And they were well-meaning, don't get me wrong about this. But I said to them, someone once said that the law should be stable but never static. But medicine is neither stable nor static. And so we have to understand that and build in the flexibility. Now, you as Congress, in your rightful authorities and positions, should have oversight. And so what we owe to you is a mechanism for bringing to you what we have done and being accountable for what we have done, but we need to have the flexibility to modify and improve the program to make it, again, the exceptional program that the beneficiaries deserve.
How many lives, if any of you know, how many lives are covered by TRICARE today?
9.5 million.
Yeah, I mean, that's bigger than many health insurers. That's a lot of lives. One would think that we should be able to create a form of TRICARE that's competitive with anything.
You bet. That
the private market can offer and that can evolve, just like the private markets evolve. And I would encourage a continued dialogue because I think there's the potential for that could possibly overcome some of these hurdles that, and as I said, I started as, we've had these discussions, I started as an advocate for change, but sometimes sometimes the cure can be worse than the illness, and so I think maybe we need to explore this more. I yield back. Thank you.
Thanks. And I want to go back at Dr. Woodson. Thanks for the, pointing out all the things that the commission would require you to do to set up this new program. And as we move towards the idea of value-based care and having that single point of accountability and contact for a patient in a medical home, it goes back to the previous question that I had is there, benefit in looking at, do we bring pharmacy benefits back in-house to the TRICARE ASOs? The nurse advice lines, which right now don't go to the ASO, so you got somebody calling for nurse line advice that's unrelated to the actual healthcare provider that they're going to wind up seeing. So I think it's, as my colleague said, as we evolve and try to maximize the benefits of what's happened on the outside of the military healthcare system, again, we need to come up with how do we give you the authority to be as flexible and agile as you need to be, right? And to the Surgeon General's topic we haven't discussed yet, your opinions on the idea of a unified medical command. What do you think are pros versus cons in 3 minutes, 58 seconds?
Oh, real quick. The commission actually recommended a joint readiness.
We've taken that one off the
taken
table.
that off.
But,
Okay, so
we're just
you're
talking about
asking
specifically
specifically-
a unit, kind of like a transcom for medicine.
You know, I think right now we've spent so much time and energy, and we're starting to see some progress in the 10 shared services. I think we need to allow that to continue to progress. We have really worked with standardizing our capabilities and looking where we need to be more interoperable. And so I think there's some goodness in cost savings and also just standards that will be common across the board to decrease unwarranted variance. So I support the direction of refinement of where we've been going with the Defense Health Agency and then common business processes across the board.
Okay.
Yes, sir, I agree. I think if you look at what's happened over the past 3 years, there's been substantive change in the military health system. We've worked together jointly under a new governance process. We've stood up the 10 shared services with the Defense Health Agency to gain efficiencies and effectiveness in what we do in common. We train our enlisted out of a joint platform. We have a medical school where our physicians train together. And we have a lot of our hospitals now more than ever that are jointly staffed. So I think what you're seeing is a significant evolution in the way we work together jointly in our home station medical support.
Sir, I'd agree with that. You know, we have been doing this for a long time. All our IT systems are architected jointly so that no matter where you go and what facility you're in, your healthcare record is available. We deploy our staffs together. You know, when I was deployed in theater running a combat hospital, I was a commander of a joint task force. I had Army and subordinate Air Force units working for me. We worked together side by side. In San Diego, when I was in garrison, all the wounded warrior care, physical medicine, and rehabilitation was provided by Army physicians. We trained Air Force pediatricians. We've been doing this. So I think and now we've evolved to these shared services. I would recommend we give these an opportunity to mature and then step back and say, what problem are we solving?
All right. And General Ediger, thanks for putting out a plug for Uniformed Services University, one of the finest medical schools in the country, and no better military medicine school in the world. I was on faculty there for 4 years. Ms. Davis? Keep going until I ring the bell.
Thank you, Mr. Chairman. I might just ask if you're seeing any outstanding cultural issues in that integration as you move forward with jointness.
Ma'am, I'll address that. I had the privilege of visiting San Antonio for our combined enlisted training program that we run for all our ACE school corpsmen, our medics, our technicians, and they all get their training together now. And although we preserve our service culture, so we teach our corpsmen how to salute and the different signal flags and things like that. What really impressed me the most was when I looked down into the courtyard, I saw Army, Navy, and Air Force young, junior enlisted folks working together, making friendships and bonds that were going to carry them throughout their careers. I haven't seen service cultures. You know, we have the banter that goes back and forth where I'm trying to learn how to say hua, and I'm at the same time teach my Army colleagues how to say oorah. But when push comes to shove, when we're at the bedside, we're taking care of a patient as one team. I haven't seen cultural issues.
If I could just give an example, when the issue came up with the capabilities that needed to deploy in support of the Ebola mission, it was all three services coming together and saying, let's look at how do we do this jointly. We looked across our facilities as Surgeon Generals and identified the capabilities that was needed. It was a tri-service effort. We went down to San Antonio. It was all services coming together, developing the training plan, and then they were ready to support that mission. That is a whole different way in which we have approached those types of missions.
I agree. We've learned that culture is important because we're part of a mission, and so when we deploy our medical folks out to work within our missions, they need to be able to work within the culture of our service. But at the same time, we've learned that culture should not and does not get in the way of the way we take care of our patients. And so I think we've learned how to strike that balance appropriately.
Thank you. Thank you, Mr.
Yeah, I'd like to continue that discussion that I suggested a few moments ago. And it's how can we give you more flexibility today? In broad strokes, are there 2 or 3 things that we could do now structurally that would give you the flexibility not to propose programs that we then approve, but give you the freedom to explore, to act, to try things without an act of Congress? You know, those broad changes. Are there things we could do today that would allow you to change the current program?
So thank you again for what I think is an extraordinarily important question. In the spirit of, again, medicine isn't stable, we need to develop legislation that gives authority, I think, to the Assistant Secretary of Defense to define a process for evaluation involving medical technologies for inclusion in the program, and then include them, even if it requires a subsequent follow-up evaluation of their efficacy at some point in time in the future, and that ought to be broad. I think that's really very important because, again, medicine isn't stable. New ways of treatment evolve every day. And the way the language reads now, it's pretty rigid about the evidence-based the requirements for evidence, and that sort of stalls us a little bit. I think there are some other things that we need to deal with to synchronize our efforts. So one of the things that the Surgeon Generals and my office have come together on is looking at new models in which we can manage markets, optimize the use of the military treatment facilities, and optimize the use of the purchased care market. And so there are going to be some new, I think, authorities that will need to allow patients to flow from the market to the MTFs to ensure we have the proper case mix. This to include new ways of attracting Medicare eligible or aged patients, whether or not we actually define and establish a sort of Medicare Advantage within the MTFs. We need to be given broader authorities, I think, that relate to taking care of veterans. I think, in fact, there's even an opportunity for us to take care of DoD civilians. And, in fact, you know, we have a lot of dual eligible folks who, in fact, work for the federal government and they have TRICARE benefits. Well, why not allow them to use their TRICARE benefits within the MTFs? See, I think this would lead to proper utilization of the MTFs, proper market management, meet the case mix, skill mix issue, and actually allow us to deliver extraordinary service to the beneficiary population. So those are some of the things. There are other things that we could talk about, but you know, off the top of my head, that would be some of the things we would look forward to.
Let me explore one other, and happy to have any of you answer. In the private sector, you have a constant dynamic interaction between the provider of healthcare and the financer of healthcare, and it's largely how the private sector healthcare system has evolved. That tension between high quality of care and affordability, and everyone hates it, but it works well. You don't have that, as you observed earlier. TRICARE is not insurance. We're the financer of healthcare on behalf of the American taxpayer, and you don't have that same daily dynamic interchange. How does that, can you achieve what I'm talking about, what we've been talking about? Can you achieve that without this two-party negotiation going on a day-to-day basis?
I'll take that one and share it down the road. Each of us have to be fiscally solvent to be able to manage and run our healthcare facilities. And so we have very well-defined business plans. We have incentives where we incentivize our providers and clinicians for patient satisfaction, for their care experience, for health outcomes, and then we also incentivize them for readiness. So We've moved as we improve readiness. That is something that they get incentivized and financial rewards for that. And moving even more so in a complicated system of looking at how do we really move towards outcomes and functional health. So this movement from healthcare to a system for health is a huge culture change that your financial system has to be able to drive it and support it.
Yes, I think really the answer to the question you pose is really the value-based approach to providing health care. And I think to do that, we've got to define and consider and measure and manage the performance and value in all of its aspects. And so that's quality, that's safety, that's patient experience, but it's also cost and efficiency. And the performance management system that we've built in the direct care system in the action plans that followed up the MHS review last summer are really focused on all the aspects of value, including cost and per member per month cost, those kind of things. We are now managing to that as a metric. So I think really the answer is value-based approach to providing care.
And, sir, also adding into that flexibility. Flexibility, as we talked about earlier, and agility. Healthcare is dramatically changing, and it's impacting the military because, as I shared earlier, 75% of our uniformed force were born after 1986. How they make their healthcare decisions and what influences those decisions is fundamentally different than what influences us as baby boomers. And so they pursue convenience and the experience of care and increasingly technology. Having the agility to pursue value-based options using those things without requiring them to come to a hospital for their care is fundamental to our success and really an operational imperative. So the things that you could do to help us to give us that agility is really where success is going to lie.
Thank you, Mr. Chairman. I appreciate your indulgence. I was making up for lost time earlier. I appreciate
well done.
it.
Appreciate your very informed questions. So I agree with Secretary Woodson's comments about trying to attract more consumers of healthcare into our MTFs to provide a better training platform for our military healthcare providers to be better ready. And I think that was really one of the places where the Commission missed the mark, because certainly when they presented to us, they seemed to be focused on the idea of the MTFs being training platforms solely for combat casualty care, not realizing, as you well pointed out, General Horoho, that the vast majority of folks that we treat are not traumatic injuries. So the question is, if we are you get the authorities and the flexibility, and the marketing campaign is successful to bring in more lives into the MTFs, is there capacity within the MTFs to be able to absorb a higher patient volume, whether it's maybe we go to a Medicare Advantage type TFL product, or if we go out and try to allow DoD civilians to participate and receive their care at the MTFs. Are you going to be able to absorb that increased patient volume, and will the costs associated with caring for those new patients keep your business plan in the black?
So let me start, and again, I think the Surgeon Generals really need to weigh in on this. So first of all, within the MTFs, we have fixed costs. So if we take care of one patient, the cost of care for that patient is extraordinarily high. If we take care of more patients, of course, the costs go down, and there's some built-in cost of readiness, which is the issue we're talking about in terms of maintaining skill in the graduate medical education program. So the bottom line for me is that there is capacity. I think what we've been working on is retooling how we're thinking and how we're managing to make the system clearly more efficient and to make us a preferred provider. And I'll stop there and let the Surgeon Generals talk.
And, sir, just in two areas with that, it would be very helpful to be able to have a diverse population that we could care for, but it's going to have to be tied to our readiness. What is the complex cases that we need to really support our training programs and increase our medical readiness of our providers and the support staff? With that, though, it's going to require a commercial financial system and a business intelligence system, because both of those are capabilities that we don't have right now, and we'd need to be able to do that so that we could bill for certain services.
So the care that's needed to help enhance and support our readiness is specialty and inpatient care. And in Air Force hospitals, yes, sir, we do have capacity. I think as we potentially gain the ability to more effectively capture care, that's the kind of care we would need to we would want to capture. And so I think we would need to go about it in a way using the business intelligence systems where we were capturing the kind of care that's most relevant to our readiness, and that is the kind of care where we have capacity. Our hospitals are fully enrolled, and growing our primary care workforce is really not what we need so much on the readiness side as it is to pull in specialty and inpatient care.
Sir, I would agree with the other panel members. We not only see unit costs go down as you see more patients, but there's an inherent efficiency in the staff so that you see more patients much more efficiently and you get better outcomes. And so long-term costs are down because you're getting better outcomes keeping people healthy. Short-term costs are down because you're not using as many things to take care of them in the short term. So I think there are inherent efficiencies to do that. We have capacity to do that. But as General Ediger and General Horoho said, we have to be selective. So we don't want to recapture all of one thing. We really need to look at what exactly do we need for our mission and then go after those. Business intelligence is critical for that, and we don't have that right now. And so I think that will be an important tool that we'll need in our toolkit to go after those things.
That's perfect timing, Admiral. Well, I want to thank all of you, one, for staying with us even though we started late, and for your answers to the questions here today. Obviously, we look forward to continuing to work with all of you to make TRICARE the premier healthcare provider in the nation, and want to again hail Lieutenant General Ediger to our group, and farewell to General Horoho. It's been a pleasure working with you, and I'm sure we'll be talking to you soon. This hearing is adjourned.